Dr. Folkerth is a neuropathologist with clinical and research experience in traumatic brain injury, neurodevelopment, and forensic issues. She was trained by the late Dr. William Shoney at Brigham and Women's Hospital, Dr. Hannah Kinney at Boston's Children's Hospital, and the late Dr. Richard Hewlett at the Universities of Stellenbosch and Cape Town in South Africa. Dr. Folkerth served as the Director of Neuropathology service at BWH and of the NP Fellowship Program until 2016, where she became the neuropathologist for the New York City office of the Chief Medical Examiner. In 2023, she became a member of the Brain Injury Research Center at the Icahn School of Medicine at Mount Sinai. I will now turn it over to Dr. Folker.
Hi, everyone. Thank you so much for joining me today. I'm going to talk with you about sudden unexpected death in epilepsy and genotype and phenotype correlations as we know them so far. I don't have any disclosures, and I'd prefer it if we didn't have social media sharing, although I understand this will be on YouTube one day. I'm going to try to review the epilepsy and SUDEP definitions in epidemiology so that you have a good understanding of them. I'd like for you to be able to describe the gross and microscopic features that should be evaluated when one does a neuropathologic workup of a seizure disorder. And you should be able to explain the role of genetic testing in cases of epilepsy and how to select cases which may benefit from molecular diagnostics. So let's begin with the definition of epilepsy, also known as a seizure disorder. In my understanding, these terms are interchangeable, and that's based on many years of working with my neurology colleagues at Brigham and Women's Hospital in Boston, who were epileptologists and with whom I worked every month on reviewing any cases with them that came to seizure resection or autopsy. So epilepsy or a seizure disorder is diagnosed after 2 unprovoked seizures. That means without some sort of known toxicological or other exposure that resulted in the seizures. They can either be focal, sometimes called partial, or generalized. Focal ones can be characterized by cognitive, emotional, sensory, and or motor symptoms. Sometimes these are difficult to actually recognize as seizures, and only in certain settings may an experienced neurologist be able to recognize them. They can be simple, in which the consciousness is maintained, or complex, where amnesia can ensue. Generalized, I think we're much more familiar with those. They can result in complete absence or petit mal, or grand mal, where there's tonic, clonic, or usually combined tonic-clonic movements, GTC seizures. They can also be atonic, also called drop attacks, or myoclonic, characterized by muscle jerks. Among children, about 3 to 5% will have a single febrile seizure in the first 5 years of life. That by itself does not qualify as a seizure disorder, and usually they're associated, as the name implies, with a fever. Um, Among these, about 30% will have more than one febrile seizure, again related to a fever or an illness. And among these, 3 to 6% will later develop afebrile seizures or epilepsy. Epilepsy itself is a cause of significant morbidity. This is a paper from the National Burden of Epilepsy of Global Disease. And you can see in this top map, this is the age standardized years lived with disability. In other words, people who have a severe problem dealing with their activities of daily life because of their disability. And you can see that there's concentration here in the continent of Africa and South America, and that northern populations have somewhat better uh, control, access to medications, and therefore fewer years lived with disability. And here you can see the prevalence of idiopathic epilepsy per 100,000 individuals, and it's somewhat mirrored in the same way. Not only is there significant morbidity, but there is a 2 to 3-fold increase in mortality as compared to age-matched controls. The risk is highest in those under age 50 and in the first years after a diagnosis of seizure disorder is made. Of course, as you might expect, this often relates to the substrate actually causing the seizures. And as we well know in neuropathology, since we see tumor resections and sometimes cerebrovascular disease that results in epilepsy, these are oftentimes the actual underlying cause of the death. And you wouldn't necessarily invoke SUDEP or sudden unexpected death in epilepsy in these cases because they have an underlying natural disease. So, what is SUDEP? It's a fatal complication of epilepsy. It's defined as the sudden and unexpected death, which is non traumatic and non drowning without a toxicological or anatomical cause of death after a complete autopsy. This does not include deaths that occur during status epilepticus. That in itself is considered a fatal disorder, potentially fatal disorder. So it wouldn't be SUDEP. And sometimes this can last for some period of time and therefore is not exactly sudden. The usage of the term is used again clinically among epileptologists, but also forensic pathologists may use the term for death certification. And in fact, if you haven't had an autopsy, again, you wouldn't really be able to use the term as definite SUDEP. It accounts for 7.5 to 17% of all epilepsy-related death, and the risk is much higher among those who have what's defined as medically refractory epilepsy, that is, requiring 3 or more anti-seizure medicines for even some degree of management, may not even be complete control. The causes of SUDEP are multifactorial, and they include obviously cerebral causes, but also cardiac and respiratory causes. And we'll go over a little bit more of that with when we get to the molecular genetics. The incidence is as you see here. Most reported cases are in young adults, 18 to 40-ish years. Men have a much greater risk of dying of SUDEP. If one suffers from generalized tonic-clonic seizures, the risk is tenfold higher. And if one has 3 or more such seizures per year, the risk is 15-fold higher. Obviously, those who are in poor compliance with medication or don't have access to medication also have increased risk. And importantly, the state changes that occur during sleep are thought to be a primary risk factor for the autonomic instability that leads to seizures. And we'll talk about that here. If one does what's called a sleep hypnogram to actually look at the neural activity across the different steps that occur during sleep, from waking to S1, S2, S3, non-REM sleep, slow wave sleep, during the course of a night, an individual will pass through these phases several times, and each time they have a longer period of rapid eye movement or REM sleep. And as you can see, each stage is characterized by a different EEG pattern. And when one moves between these patterns is when there is the potential for autonomic instability that can occur and can lead directly, it's thought, to arrhythmias and sudden death. So oftentimes, SUDEP is noted after a sleep period, similar in many ways to sudden infant death syndrome or sudden unexpected death in childhood. And the thinking is that in an individual with epilepsy who suffers a generalized tonic-clonic seizure induced during one of these transitions through a sleep state, there is spread of the activity to the midbrain, leading to ascending arousal system inhibition. You recall this is required for normal arousal and awakening, so that this, when it's inhibited, one has loss of arousal. Spread to the respiratory centers in the medulla can lead to respiratory nuclei inhibition, serotonin neuron inhibition, again, similar to what is thought to occur in sudden infant death syndrome, and then also spread to the cardiovascular centers in the medulla. And each of these things can lead either on their own or in a synergistic fashion to hypoventilation and apnea. Excuse me, which can lead to cardiac autonomic neuron dysfunction, arrhythmias, and sudden unexpected death. Now, one of the things that happens after a seizure, you can see here this disoriented activity, is that after the seizure, there's postictal generalized electroencephalographic suppression, and that this is also thought to play a role in this. Now, when individuals are worked up with sleep EEGs in the hospital and observed, this is when a lot of these observations have been made in individuals. Now, notice that congenital long QT syndrome or other intrinsic cardiac dysfunction can play a role here. And part of what I hope we'll uh, learn together through this talk is the overlap between cardiac and neural mechanisms of sudden unexpected death. Here's the brain, which responds to internal stimuli, interoceptive stimuli, but also to external stimuli. And these are mediated through differential areas of the cortex, dorsolateral prefrontal cortex, and through the thalamus and brainstem. What I want to also point out is the importance of the anterior and posterior insula. The insula, now we all know the homunculus, where the legs, the motor of the legs sort of hangs into the hemisphere, and the arms and head are on the outer aspect of the hemisphere. The insula serves as the cardunculus because it has a somatotopic relationship with the brainstem that leads to cardiac and blood pressure and respiratory regulation. And this happens to be a plant that's also called a cardunculus. And I think it's kind of fun how it looks a little similar to it. So just to keep that in mind. And once in a while, one might encounter a case clinically that I know I've seen a couple where an individual has had autoimmune encephalitis affecting the insula, and they will present with primary arrhythmias, cardiac arrhythmias. So it's an important thing to be aware of. Now, the types of SUDEP, as I mentioned, if before one can call it definite SUDEP, one has to have a postmortem examination. And you may or may not have evidence of a terminal seizure. And for those of us who do autopsies in this setting, you might look for tongue bites, that kind of thing. Um, and you have to be sure that you're not dealing with a status epilepticus that was unrecognized. Sometimes could be a challenge. If one has an autopsy that also reveals other comorbidities, such as cardiac disease, this could be definite SUDEP plus. Now, these would be signed death certifications as manner being natural. If one does not have an autopsy, then one can only call something probable SUDEP, with or without a comorbidity. And possible SUDEP indicates that there may be a competing cause of death. That could be something like accidental asphyxiation during the course of a seizure, from wedging. And in that case, it may be difficult to discern between a natural event or an accidental event. And then you have these others here, which I'm not going to discuss. So the overlap between SUDEP and cardiac death is really is profound, and it sort of depends on who is looking at it. If you don't have an autopsy and you're a cardiologist, you may presume that there's a cardiac disease if you know that there's onset of cardiac type symptoms ahead of time. Same with a neurologist. If they have epilepsy, clinical epilepsy, then one's going to consider that. If you have an autopsy and the person has no history of epilepsy, this is when one would arrive at the diagnosis, or the cardiologist working with the pathologist would call it sudden arrhythmic death syndrome, okay? Versus an individual with a history of epilepsy would be called definite SUDEP. Okay, I'm hoping that that is relatively clear. And I want to highlight, as always, as you all who know me know, I firmly believe that autopsies are extremely important in helping us not only delineate causes of death, but determine which cases should then go to testing in order to determine whether family members may be at risk of similar events. Again, this overlap is highlighted here in this diagram. And if you have solely non-cardiac mechanisms of death and a history of epilepsy with an autopsy, you can call it SUDEP, or if you also have cardiac, it would be SUDEP plus. And then the sudden arrhythmic death syndrome is here, or sudden cardiac without any epileptic manifestations. But the overlap is sometimes that makes it look like it's easy to sort, but it actually sometimes isn't. Now let's talk about the structural substrates of epilepsy that we're likely to see at autopsy. Of course, old contusions or other uh, traumatic injuries to the brain, gunshot wounds, penetrating injuries, whatever, can be associated with epilepsy. Those are usually fairly easy to pick out at autopsy. Then there's a whole host of developmental lesions. These can be primary malformative, occurring with defective organization programs in utero, such as focal cortical dysplasias, malformations of cortical development, and so on, with neuronal migration disorders, heterotopias, or they can be disruptive, i.e., acquired. Now, some of these can be acquired in utero or in the perinatal period. And because the brain is still developing, you will get disorganized development, but it's not the same as having a primary morphologic neuro developmental program that has gone awry. Something has interfered with it. Post meningitic is another one, especially in meningitis in early life. Now, I'm other substrates that can be structural or not for seizures include obviously tumors, vascular malformations. We well know these. Rarely neurodegenerative disorders can result in seizures, and obviously toxic and metabolic alcohol withdrawal being one of the main ones that one will see. Now, having an agonal hypoxic seizure before death is not considered epilepsy, and we're not going to cover these today. I think most of us see a fair amount of these kind of lesions in our regular hospital practice. Let's talk about the hippocampus in epilepsy. We know it's a major player. There's either hippocampal or the term mesial temporal sclerosis. They tend to be used relatively interchangeably. If one wants to be more careful or specific about it, one would use hippocampal sclerosis when you have gliosis and neuronal loss in Ammon's horn. CA4, for example, end folium sclerosis with or without CA1 or CA3. This would technically be hippocampal sclerosis. If one also has evidence of neuronal loss and gliosis in the subiculum, temporal neocortex, parahippocampal gyrus, and the amygdala, one may decide to use the term mesial temporal sclerosis. Um, again, I think it's sort of a matter of preference, and the implications of these are kind of the same in that they can be considered the cause of epilepsy or an effect of longstanding epilepsy. And these changes can accompany any other substrate, including the ones I've mentioned, like focal cortical dysplasia and so on. Hippocampal dysgenesis is a very interesting concept. It's evolving the understanding of it over what are the actual pathognomonic features. At this point, there is not, uh, in my view, a consensus as to what constitutes hippocampal dysgenesis. What is known is that in a subset of individuals with what seem to be structural abnormalities of, for example, the dentate gyrus, and I'll show you some examples of that in just a second, there is a relationship to a personal or a family history of febrile seizures, best recognized in toddlers. And in some centers that have the capability to work up family members with imaging and so on, one can see structural abnormalities in the hippocampus that could be consistent with hippocampal dysgenesis. But I think, I would advise you to stay tuned on this. This is a rapidly evolving area and it's extremely interesting. So there are a couple of protocols that are out there that are in use. This is from the Royal College of Pathologists. and what they recommend for autopsy practice. This is from 2019. And obviously, we know many of these. Professor Tom, for example, has defined a lot of the changes that are seen in longstanding epilepsy. The idea is to identify the structural cause, as we just talked about, the common lesions that are present and go along with the occurrence of epilepsy. And they make the point, and I would emphasize this, there's no evidence that any single neuropathology is more often associated with SUDEP. I don't believe that wisdom has changed in the last few years. What is also desirable during these cases is to look for evidence of previous or recent seizures. That could be acute neuronal ischemia, cerebellar atrophy, which can be related to ischemia, but also to longstanding dilantin therapy, for example, cortical atrophy, scarring, and evidence of neurosurgery. If there's been temporal lobectomy or invasive monitoring, one would want to definitely document all of that. And this is what they recommend sectioning. I won't go over all of this. One can refer to the paper itself. As you can see here, watershed areas, some of the basal gray, hippocampus, and brainstem and cerebellum. A position paper was published by the National Association of Medical Examiners in 2018. This borrowed heavily from the paper by our colleague Ross Reichert and Rachel Vaubel from 2014, in which, of course, they mentioned the necessity of a death scene investigation because you want to know, the body position, were the medications present at the scene? Had they been properly utilized or not? Obviously, one would do toxicology looking for blood levels of these medications. Were there witnesses to the behavior or to any activity during the evening or when just before the death occurred? And their suggestions, which are also reflected here, are hippocampus, right and left, amygdala, watershed areas, and again, these areas here. Now, at the New York City office, I found as I went through these on many cases that I wasn't really getting much information from some of these sections. So, because of we were a resource limited setting, we I as I reviewed all my cases, I went back and looked at which ones actually gave me information that mattered for the diagnosis. And so I developed this, which is in use. I haven't published it, but I just offer it as in terms of practical guidelines. Obviously, you want the right and left hippocampus. It's good to get it at the LGN because the anatomy is the most reproducible there. You can put the amygdala right and left in the same cassette and just notch one of them so you know which is which. I take the triple watershed of the parieto-occipital cortex, looking for acute neuronal ischemia, the cerebellum, and obviously, if you see an abnormality, you take it, right? As we do in every case. This is what my protocol looks like. You can put the amygdala in one cassette, again, notch one side, and it fits quite nicely. The left and right hippocampus in their own cassette, the triple watershed here, and this is what I call my all-purpose cerebellum section, which includes the vermis, the white matter, the dentate, and the cortex. And that gives you a pretty good idea of what's going on. Obviously, if you see something cuckoo, you take that too. Um, Let's move now to molecular testing studies in epilepsy. So we've got our clinical history, we've got our death scene investigation, we've got our brain analysis. How can we gain further understanding of what's going on in a given patient? Now, this is an earlier study, or actually from 2022. This was done in living adults with epilepsy using a next-gen sequencing based gene panel where they looked for these different variants and so on. They classified them, as is done in molecular genetic settings, as benign or likely benign, of uncertain significance, or VUS, or pathogenic, likely pathogenic. They looked at 2008 unrelated individuals. They tested them at a mean age of 28.7 years. That's when they were tested, but their onset could be as early as infancy, early childhood, late childhood, adolescence, or adulthood. So that's how they separated their results based on the onset of epilepsy in the individuals in their cohort. And what they found was that using their molecular genetic testing system, they found diagnostic findings in a little over 10%. 19 had negative findings, in other words, benign, likely benign, for the panel that they had. And some, and this is pretty much the usual experience, that these would be considered non-diagnostic or variants of uncertain significance that hadn't been specifically reported as known deleterious variants in the past. And what I want to highlight here is that they show, excuse me, the cohorts. Remember, these are tested in adulthood, but their onset of their seizures was in infancy, early childhood, and so on. And you can see that the yield is much greater in infants. And these reflect most often sodium channelopathies, as you can see here. And that when one is tested as an adult, there's a bit of a different spectrum of findings that come up. And that's basically the point I want to make, is that there is some variation in the expression across the age at which the epilepsy is first noted. The other thing that they show here, again, with the seizure onset, is the percentage. It's a relatively lower percentage of cases that have onset in adolescence or adulthood. But what they do point out here, which I think is also important, is that a significant number have autism spectrum disorder. Depending on the literature you read, up to 50% of individuals with autism spectrum disorder will have seizures. Again, autism is not one disease and can include all sorts of things that can have structural abnormalities. But I also want to point out here that these have intellectual or developmental disability, a huge number. And again, this goes back to the map I showed earlier on about the morbidity of epilepsy in the patient populations that have it. And you can see that they're increased here in intellectual disability or developmental disability. Now, part of the point of this paper was to identify clinically actionable genetic findings. And a certain sector didn't really have, it didn't change anything in terms of management. Um, some, it suggested there was surgical contraindications or indications, and same with anti-seizure medication indications or contraindications. And some suggested the need for a metabolic therapy. So this is interesting, but I want to remind you, this paper had no pathology. These were living patients that they analyzed. Here's a paper that did look at sudden unexpected death in epilepsy using an exome-based analysis, and they included cardiac arrhythmia genes, respiratory control gene, and epilepsy genes. So I remember these are highly overlapping in terms of their um, incidence and penetrance. They had 54 definite SUDEPs, 2 SUDEP, definite plus, and 5 probables. And this was their protocol that they used. And they found that, again, the age at epilepsy onset tended to skew relatively young, from even infancy, from neonatal period. But the age at SUDEP also could be very young, and overall, as mentioned in the previous statistics, it tends to affect those under 40-ish. They found in 46% de novo mutations, 7% had long QT syndrome variants. As we mentioned before, those are known risk of arrhythmic sudden death. 15% had candidate pathogenic variants in these genes, and 25% had variants in dominant epilepsy genes. And these are among the ones that were the top 30 genes genome-wide. Again, these are channelopathy genes. And here, if you look at those with cardiac arrhythmia genes and what neuropathology was available, a couple of these, this one had hippocampal sclerosis and mesial temporal lobe epilepsy, and this one had a temporal heterotopia. And then in the ones that had variants in epilepsy-related genes, you can see some had temporal lobe pathology, structural lesions, um, microcephaly, dysplasias, and so on. And then some of these were syndromic, known to be syndromic. So we decided to look in our own practice at the Office of the Chief Medical Examiner, and this was work spearheaded by Michelle Stram, who's at Mayo Clinic now, and with the help of Ying Tang, who's the molecular geneticist at the OCME. And we received cases over a 3-year period, any that had epilepsy or seizure on the death certificate, or cases in which the ME requested molecular genetics because the usually child or individual had a seizure disorder or a syndrome, such as Lennox-Gastaut. We excluded those that were known due to trauma or alcohol or drug withdrawal or some other terminal metabolic event. In other words, that you wouldn't necessarily call a seizure disorder clinically. We did a standard examination, and we did additional histologic sections on all the PD cases because we have a more extensive protocol in the PD group. And then we correlated with NP features that we defined a priori, and I'll show you those in a second. This is our gene panel, which obviously I won't go over in detail. But these were known to be associated with dominant epilepsy syndromes, with early childhood onset, voltage-gated channels, and so on and so forth. We didn't include those that are available on the newborn screening panel or mitochondrial or epigenetic disorders. And again, we would either take tissue, place an RNA later, or a blood spot card for DNA extraction, fragmentation, and next-gen sequencing. And this would go through a series of analyses before being reviewed by the chief of the molecular genetics service. And the features that we looked at to try to see whether we could have any correlation between the genotype and the phenotype, we looked for macroscopic evidence of any kind of dysgenesis, including hippocampal asymmetry, which I'll show you in a second, any gyral abnormalities, nodular heterotopias, and so on. We all know what those are. Microscopic lesions would also include dentate gyrus irregularities or bilamination, and this was based on the suggestion earlier on by Dr. Kinney that there may be association of irregularities of the dentate gyrus or hippocampal dysgenesis with sudden unexpected death in infancy and pediatrics. We also documented end folium sclerosis, which is in CA4, as I mentioned, whether there was MTS or neuronal loss in any of the other segments here. And then we looked for evidence of dysplasia, all of these things here, and any other epilepsy associated findings. And it's a bit complex, but I'll show you some of the things that we used. For example, this is a toddler that had some asymmetric hippocampi. This one here looks pretty normal, normally infolded. This one you see has a funny kink in it, a sort of a vertical orientation or an incomplete rotation. And these microscopically, not always, but would often be associated with dentate gyral abnormalities, including this sort of tram track bilamination of the dentate gyrus. We also looked for examples of mesial temporal sclerosis or hippocampal sclerosis. Here you can see this has actually got some atrophy here in CA1 of the hippocampus. And here you can see this. I don't know why this picture is a little funny, but the neurons you can see sort of die out in here in CA1. You can see there's just a couple neurons, but mostly gliosis and rarefaction. So that would be an example of hippocampal sclerosis that we would document. And again, this is in CA4, so this would be end folium sclerosis. You can see there's a decrease in the number of dentate gyral neurons. And you would also notice gliosis here in CA4. I personally don't ever get a GFAP on these. I think they can be misleading. If the gliosis is there and it's real, you should be able to see it on H&E with no problem. This is a nice uh, panel from Professor Blumke's paper showing with a new N immunostain the normal distribution of the dentate and the pyramidal neurons in the hippocampus. Here we have only loss in CA4, again, and folium sclerosis. Here it's in CA1 only, similar to the one I just showed you a bit ago. And then here, these have variable loss in other sectors of Amon's horn, usually with sparing of CA2, but not always. And then here's an example that we came across of focal cortical dysplasia. These can be exceedingly subtle. This particular case, I stared at for quite a while before I decided that that this superior temporal gyrus just looked a little too funny and mushroom-like, similar to a tuber, cortical tuber, and you can see it's not symmetric with this one here, and it's obviously, not a completely symmetric cut, but that seemed it stood out to me. And sure enough, this was focal cortical dysplasia. You've got neurons with apical dendrites pointing every which way. You've got enlarged neurons through the whole span of the neocortex. And this is quite a nice paper, by the way, on features of focal cortical dysplasia compared to normal cortex. So this is what we would use to try to, as an example of identifying that. Obviously, gross gyral abnormalities, as we have here, where you've got simplification or maybe complexity of the gyri, with evidence microscopically of disorganization, nodules, poor distinction between different layers, and so on. These are nodules that were identified in one of our cohorts, periventricular nodular heterotopias, and then subarachnoid glioneuronal heterotopias with disorganized neural and glial tissue sitting there in the subarachnoid space. So what we found, we had 79 cases, again, ranging from 2 weeks to 47 years. And we had likely pathogenic or known pathogenic in 3. And again, these were cardiac channelopathies, but they did have mesial temporal sclerosis or end folium sclerosis. This one also had a subarachnoid glioneuronal heterotopia. Variants of uncertain significance, similar to that first paper I reviewed with you. This is often the case because obviously when one reports a mutation as known, one has to look at the family pedigree and have some genetic analysis, clinical analysis, to know for sure whether it's pathogenic and responsible for the abnormalities. But we did find these in 33 cases, and they were some of them associated with hippocampal dysgenesis, and so on, as you see here. And some had end folium sclerosis, again, the channelopathies, and so on. And there were some that, again, channelopathies that didn't really have any neuropath findings with these um, VUSs. And then benign or likely benign in a good, about half of them. And some of these were known syndromes and had neuropath findings. Others did not have a known syndrome, but had some interesting pathologic findings. Again, does this just mean we don't have enough genes on our panel to recognize the responsible mutation? Probably so. I mean, you can only go by the ones that you know to put it in the panel. And then with discovery, of course, the panels get larger. And what we were able to summarize here is that among those with neuropathologic findings, we had quite a number that had periventricular nodules, subarachnoid glioneuronal, mesial temporal sclerosis, and so on, but they didn't have any known pathogenic or likely pathogenic variants. Then we had some that were syndromic that did have some neuropathologic manifestations and did have some molecular genetics. Then we had a large sector with VUSs and pathogenic or likely pathogenic, some of which had neuropathologic findings here, some of which were syndromic. And then you had a lot of these that were kind of in between here that had neuropathology but didn't have a known pathogenic, likely pathogenic. And it could be that over time, with additional testing in more cases, these will turn out to actually fall into the purple, pathogenic, likely pathogenic. So it's a little, I think it's not as neat and tidy as we would like it to be. Of course, life never is. So I want to just sum up here and conclude and leave a couple minutes for questions. That epilepsy results from a number of structural brain abnormalities, as we all know. A subset results from channelopathies, which can overlap with cardiac rhythmogenic syndromes. And these are really important to recognize when we can, because the family members potentially have an increased risk of sudden death that could be prevented by the administration of appropriate medications. And I will say that one of the nice things about the Office of Chief Medical Examiner in New York, and that I think is being picked up by other centers, is that we have a dedicated clinical geneticist who's on faculty and reviews all these cases, reaches out to family members, will meet with them and make referrals for any family members that are at risk of sudden death, so that we actually are doing quite a service for the living. It's I think very important, and I'm very proud that the New York OCME has spearheaded that. And again, you guys have heard me, I'm a broken record. I really believe in autopsies for accurate diagnosis and certification of all deaths, but especially in sudden unexpected death. Forensic settings are front line, but even in the hospitals, one can really make some important discoveries that were not suspected clinically or that can be confirmed. And lead to molecular testing that's appropriate for the surviving family members. And this whole field is in its infancy, so please stay tuned. And when you have such cases of interest, consider the ways in which you might pursue working them up completely. Okay, so I want to just thank Dr. Barbara Sampson, the former chief, and Jason Graham, the current chief at New York City OCME, Dr. Tang, molecular genetics, Michelle Strams, currently at Mayo, Dr. Heather Maioli is wonderful neuropathologist currently at the OCME, and then all of the MEs, the fellows, the technologists, the medical legal death investigators who go to the scenes and talk to the families, our wonderful histology lab there, evidence who keeps track of everything for us, and all former and current members of the agency. They are, in my view, unsung heroes in this world. And I'd like to thank the AANP for asking me to speak to you all. So that's all.
Thank you, Dr. Folkerth. At this time, we'll move into Q&A. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner. Once you've asked your question, please remute to avoid background noise. I'm not seeing any questions in the chat quite yet, Dr.
Hello, may I
Folkerth.
ask one? Hey, this is Murat Kaptan. Rebecca, thank you very much.
Hi, Murat. Yes, how
Wonderful.
are you?
I'm good. How are you doing?
Good.
Just wondered seeing these dentate gyrus abnormalities. We come across to them in routine autopsies out of nowhere. Dispersions, undulations, duplications. I mean, are we supposed to do anything further for those? Or, I mean, we just mentioned them, but
Yeah, it's a great question. A great question. And as I say, everyone would like the answer to this. Right now, I would say we don't know. What I personally do is if I have not detected a macroscopic asymmetry or an abnormality, I will just leave it in the description, the micro description. And if there's no known history of epilepsy or, um, you know, cardiac arrhythmias or anything like that, I would tend to just leave it in the micro. Sometimes I will say in the autopsy report, microscopic findings of uncertain significance. And my fellows make fun of me because it's MGUS or MFUS, microscopic findings of uncertain significance. So you've recorded it and it's searchable, hopefully, depending on your system, so that when we do know more about what it means, you can go back and look at these cases. If they've got the macroscopic, malformative appearance and a microscopic abnormality, I will often say something like feature suggestive of hippocampal dysgenesis. Again, and that, if they have epilepsy and there's really nothing else, then I think, one again, you just have to we're speculating at this point, but that's what I do. I like to have it recorded as a part of the report, in that way. Does that make sense?
yes, thank you very much. Do you necessarily go back and submit the other hippocampus?
Oh, I put in both hippocampi at the
Oh, all the
beginning.
time.
Yes, all the time,
Oh,
and both
oh, gotcha.
amygdalas. Yeah, but I will sometimes go back and review the gross pictures again because sometimes I'll get the micro, which will look funny, and I'll say, "Well, I didn't notice that it was asymmetric." But if I go back and look at the picture, sometimes you can pick up and say, "Oh, yeah, it is a little funny," and then you might feel stronger about wanting to report it as a finding. But I think it's hard, and I think we're waiting for um, um, more analysis, and different groups have been doing different ones, and some are showing that Doug Miller showed that he thought that these probably represented abnormalities, and then others have shown that they're not. So I think the jury is still out, and I think we owe it to be honest and careful that we mention it as a finding. But if we say we don't know what the significance is, then we're being intellectually honest. I see there's a question about using immuno. I No, I don't even use GFAP. I I don't find it helpful. If I'm looking for gliosis and neuronal loss and I don't see reactive astrocytes, a GFAP is just going to confuse me. But that's me. I know people, uh, you know, rely on their G. I'd found it not even helpful in tumor settings. But again, that's just me. Now let's see. There's another question. Yes, similar question about hippocampal malformation without a history of epilepsy. I would pretty much just say, features suggestive of hippocampal dysgenesis or microscopic features of uncertain significance. And then I might put parenthesis history of epilepsy or something like that. Yeah. Any other questions?
I was just looking through the chat. I scrolled up a little bit. Did
Ah,
you already address, are there any classifications of, is it dentate abnormalities that work?
Dr. Kinney's report from, I want to say, the one she did with Marco Hefty, I believe, goes into great detail about the different changes that she noted. And in speaking with her and, utilizing her system, in the end, she sort of felt like only the bilamination was something that really seemed more uh, important to report than the others. But if you want to catalog them, And we have done that. It's labor intensive, but that's then one can go back and actually catalog these and see whether anything pans out.
It looks like one more came through. When the epilepsy molecular panel is ordered, does it automatically come with cardiac arrhythmia panel? And have you found the connection to be common?
Yes, the epilepsy panel does include a number of the cardiac arrhythmia genes. There is a separate cardiac arrhythmia panel for individuals who don't have epilepsy, and that, again, some of those are duplicated. But if one has sudden death and there's a lot of uncertainty about what's going on, sometimes we'll get, panel A is cardiac, panel B is epilepsy, and panel C has everything. And so sometimes we'll just check with Dr. Tang, like, we've got this particular case, we're not sure what's going on. There's a family history of this, there's a personal history of that. And based on her recommendations, then she will do whichever panel she considers most appropriate. But that's a good question. I think, probably as genetic testing gets more and more, I don't know, affordable and expanded, that there's no reason to not do both. Anybody else? Oh, we
Well,
see Julie has one.
I have another one, if you don't
Yes,
mind.
please.
Yeah, I think there is this International League Against Epilepsy has an updated classification that also talks about some integrated diagnosis, just like the WHO brain tumor classification. But I am not aware of places that carry that kind of panel as a commercial service. How do we go by that?
Well, I think that's part of the problem. And that is, I mean, there are a couple of, and I'm sorry, I can't bring it to mind at this moment, but there are a couple of services that one can send material to. And I'm sorry, if I think of it, I'll ask, Ashley to disseminate it here to the group. But one can send it out, but it depends on, whether you have appropriate sample or not. You either have to set tissue aside and RNA later, or you have to have a blood spot card or a blood tube to do them. And but yeah, I've often wished that the New York City OCME would accept outside cases, but they also do all of the criminalistic work for the NYPD, so they simply don't have the bandwidth to do it all.
Thank you.
All right, well, I'm not seeing any additional questions in the chat, so thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Folkerth for an excellent presentation. This concludes the session for today.
Bye, everyone.